full knowledge to all of you all. And when we give our full knowledge to you all, we feel very, very complete. रोजी रोटी के लिए शाम को काम करना पड़ता है. So I have to work in my clinic. My wife runs this clinic. I work with her. This is my clinic. We have a very big clinic of just 100 square feet, 2 operatories with a microscope and everything. You know Mumbai, it's so very big. I think Sonali has not visited my next time. Now your daughter is also there, so you can come. Right? So now I have finished showing off myself to you. थोड़ा आपको impress कर दिया हूँ. Now we come to our pedai. So today we are going to talk about indirect composites, which itself is a huge, vast thing, wherein you will learn a whole lot of options which will help you. So I'm going to take you through this journey, which is a very interesting journey, coming straight from Japan on all Nippon Airways, this is the airline of Japan, which takes you through a whole lot of very interesting things. When I was preparing this lecture, I said, kuch hatke karte hain. So, they also understand exactly where we are coming from and how we are going to go forward. So that's your end results. You have to take off and go that high with what you are achieving as far as your aesthetics is concerned. Right? So, what are your indirect restorations comprising of? They could be inlays, they could be onlays, they could be overlays, they could be V-onlays, they could be tabletops, they could be endocrown, they could be the works. Right. Now, does anybody know the difference between an inlay and an onlay and an overlay? Anybody? No. Okay. So, an inlay would be something wherein you are going to be doing a indirect restoration on a class 2 or an MOD. Now, if you are involving one cusp in it, just one cusp in that inlay, it becomes an onlay. And if you involve more than one cusp, 2, 3 or 4 cusps, then it will go on to becoming an overlay. If you are going to add a laminate or the veneer, it becomes a V-onlay. Sometimes you might even do all the 4 cusps, that becomes a tabletop. Okay? And endocrowns, I'm sure you all the endodontists here, we love to do endocrowns. So these are the various aspects that we can inculcate or put into our practice as far as your indirect composites is concerned. Now, what are the indications? Where is it that you are able? Sir ji, isko na thoda upar kar dijiye. I come from Mumbai where the temperature, the winter is cold 22 degrees. Right, so I'm actually freezing, so suddenly I might just freeze again. So that's the reason I require. Isko na thoda sa yahan kar dijiye. Thank you. Right. So what are the indications? First thing is a broad contact. You look over here. If your contact is broad and you're not able to sort this out comfortably with a direct restoration, it's better to think about going in for your indirect restorations. If it's a large restoration, very interesting situation over here, we talk about this as we go further. How are we going to restore this? Are you going to go ahead, remove this decay, repair the cavity and lose more of, thank you so much, and lose so much of your tooth structure, or you will do something that will be able to keep us going for a longer amount of time. Here you could see how you have this circle or this wall, the circumference of your enamel, your little bit of marginal ridge, you've got enamel, then you've got dentine, you've got affected dentine, you've got infected dentine. You have to sort out all this and try and preserve as much of the tooth structure as possible. How do you decide where and how much of tooth structure can you keep and how much you cannot keep? If you use this measurer instrument, if you have 4 mm, you can keep it. This is not 4 mm, so this has to get involved because this is weak. This is a weak margin, right? So you have to get something that is more strong. Same way here. Here we can save this or we can use this. No need of taking this thing off. Keep only so much involved. Another. Same way here, you have to involve this area because this is going to be weak, right? 4 millimeters of remaining tooth structure or enamel is very much acceptable. The less it becomes weaker, the chances of you getting a fracture or a failure is higher. So when you do your case selection, be very, very clear. Cracked teeth. Cracked teeth is another indication which is a very strong indication for your indirect restoration. Here you could see a failed restoration. There is amalgam, there is secondary caries, tooth loss here. Now, how much of teeth is remaining? How much of tooth structure is remaining? If you are going to do a full crown, you are going to weaken the tooth more. Can we not save how much of tooth structure is there and give a restoration? If you are able to do that and give a restoration by saving as much or preserving as much of tooth structure is there, you are an absolute winner. Patient be khush, aap bhi khush, the tooth is going to remain for a longer period of time. Endodontically treated teeth. Now, endodontically treated teeth, it may be, if you are going to do a full crown, you are going to reduce all this by 2 to 2.5 millimeters occlusally. Do you need to do that? Right? That's where you can avoid doing a full crown in this type of a situation and try and give an endo crown or a onlay or a tabletop. Look at this. Again, a similar case. Here, endo is done. This much of tooth structure is lost on the palatal side, but we have this, right? We can preserve all this, right? Now, am I just talking off the hat? Or do I have some evidence to prove it? So, if you look at this particular paper, you will realize, this is a paper that came in Dental Materials 2024, the reduction in tooth stiffness as a result of endodontic and restorative procedures is 5%, 20%, 47% and 63% as the cavity becomes larger. So essentially, about 67 to 72% tooth structure is sacrificed during full crown preparation, whereas in partial bonded restoration, it is around 30%. This is a very, very important finding. That if we are able to give you a fully bonded restoration and preserve the remaining tooth structure, you are an absolute winner. So we are going to be talking about all these aspects in this module for you. Here you could see this particular tooth. Tell me, what do you see here? You have to speak to me. Black? Very good. So you can see there is a crack line going right from here down here into the enamel, right? These are aspects that you have to tackle successfully. Another case. When you remove it, sorry, it's the same case. When you remove it, you realize how deep the crack line is gone. So that's when the chances of we go in for your posterior indirect adhesive restorations, which will help you come out successful. There are a whole lot of materials that you can use. We all know there is lithium disilicate, there are a lot of indirect composites. We'll be talking today about this composite by Shofu, which is ceramic, which will take you through the whole journey, and we'll also give you evidence on which to use and what not to use, right? Fractures and debonding are another aspects that we need to look at. So first now, we'll start with a whole lot of cases. I'll present various cases to you that I have done on indirect restorations. Then we'll do a little bit of science, we'll do a little bit of evidence, and then practically how you go about doing it is what I'm going to do. Our first case, this was a young patient who came to me for restoration of this particular tooth, where you could see there was decay here. There was, on the face of it, you could not see because the margin was intact, but down there was a lot of decay. We went ahead, we prepared the tooth, we did a conservative approach, removed all the decay. You could see here the decay is going subgingivally. We had to take out all that, we had to put a gingival retraction cord, took out all that decay, and then we added some material there which is actually glass ionomer, and this is called deep marginal elevation. Okay, so the first thing you are learning today is DME. Likh lo. So once you sort out the gingiva or the gingival margin and you bring it up to the level of the free gingival margin, what is the epithelium in the interdental area called? किसी ने बोला? Call. Very good. Who said that? Good boy. Now, why is call called a call?
Because of its tent shape, tent-like shape.
What shape? Because of the shape. और कुछ है उसमें?
Non-keratinized.
Exactly. It is non-keratinized epithelium. So it gets traumatized easily. आप उसको छीलोगी तो भी it will start bleeding. Right? And if we have blood, if we have moisture, if we have tissue fluids, our adhesion gets hampered. The crux is maintain as much of tooth structure as possible, save as much of enamel as possible, and dry field, isolated field. Got the funda? Yeah. So once we have done that, we made the impressions. We use rubber base, light body, heavy body, whichever. We are using the functional impression technique where we use the heavy body and the flowable, which is the light body. So we are able to get a very good impression. We are able to register the impression or the tooth preparation perfectly. We also can do this with the help of scanners. Okay, we can use digitalization here. So I'll show you a few cases where I've used the scanner also. Okay. Here you could see how the preparation is made, and this is your first look of your restoration. Right? This is pre-op, this is the cavity preparation, and here the restoration is cemented in place. These are two angles for you to understand. See how it is adjusted well to the oral cavity, to the tooth, see the inclined planes, see the shape. Okay, so and it has to be in proper functional occlusion. So you have to look at a lot of things when you are doing these very specific cases. Right. So here we use ceramic. This is the solidly light furnace. This is the material we have used. Another case, indirect composite restoration. Again, another inlay. Terrible. Failed amalgam. What else do you see here? Failed amalgam and fractured amalgam and secondary caries. Very good. Can you tell me what type of caries it is? Is it soft or is it hard? It is infected or it is affected? What do you do for soft and hard caries? What do you do for infected and affected caries? Or infected and affected dentine? Complete removal of the soft caries as well as your infected dentine. How do you remove it? Spoon excavator or kuch? Smart burrs or a round steel burr at low speeds. Okay? You need to very carefully take all that decay out. Right? Right. This is with the decay out, the preparation in place. right? We've tried to remove all the decay there. We've tried to give very good KO surface margins. We've got it almost parallel, right? Because the earlier restoration, it was something like it was converging occlusally. Here we make it almost parallel, maybe about 2 to 5 degrees taper, and we do a good KO surface bevel. Okay? So once we do the bevel, then we again make the impression, and here is your restoration done. Now, when you look at this, it's not aesthetically very pleasing, right? You can play up with your shades and your tints to match this. So I'll be showing you that also. So we then went ahead and sorted that thing out, and then we cemented it, right? Now another inlay. Here it's a repeat of a metal stainless. I think this was a NP1 alloy chrome cobalt. So the thing is, there was leakage happening along these margins here, and the patient was extremely uncomfortable, and all this had got ditched. Also, you could see here there was an occlusal facet, right? So here we took that out, right? And then we went ahead and prepared the cavity, improved the cavity all over, and this is very basic thing where you could appreciate the proximal wall as well as the occlusal surface. Once we've done this, then we took a scan. Now you get your scanner, and when you take the scan, this is done on the whole file. Once the scan is done in ExoCAD, is sent to the technician, who then prepares a 3D model, 3D printed model, on which the restoration is done. So it's very easy to get digitalization into your practice, right? You need to have a scanner, you need to have all the computer that is required, and a technician who is equally trained with all this aspect. You just have to email your impression through the ExoCAD file, and the whole thing gets done. You get a cast printed instead of कि आप impression लो, उसको pour करो, फिर die cutting करो. So all those things get much more easier for you, right? Here's the trial fit that we did. When you look at this trial fit, definitely I never liked the shade, right? I sent it back and we got a better shade. This looks more like a normal thing, or you can see there are a little bit of fissures or stains that have been done in this case, okay? So we are going to talk about all that also. So how you make the tooth look more lifelike, more real, okay? It should not either, see the artificial दिख रहा है, oops sorry. This straight away looks so artificial compared to this, right? So you have to be aware of all this and then plan your treatment modality and your outcome to match what you want and what your patient expects. Right? Another onlay. This was like a huge cavity. There was some temporary over there. There was some decay. We removed all that decay, removed that temporary. Then we placed in some glass ionomer, waited for it to set well, then covered a little bit with composite, and then we did this thing called an onlay. Or not an onlay, sorry, an overlay, right? It was like almost like a tabletop covering all of them. ये सारे चिटक जाते हैं. Do all these things stick well? Do they adhere well? So then your mind has to start thinking about how are we able to get these to adhere successfully. You got it? So now you will be learning all the the techniques now between me and Mohan sir. Will teach you how to do the preparations. They'll teach you how to make the impressions, right? The restoration will come to you. You will also learn today how to do the indirect composite restoration. How are you going to stick this? How are you going to ensure that this is adhered well, right? So we will be start thinking about it now in your mind. As we proceed further, we have to understand that also, right? Here you will see how this particular restoration is adhered so well and doing well in the patient's mouth. I think this has been about a 1 year follow-up. The patients come doing quite well, right? We use cerametrometer, which is an indirect composite, right? Pre-op, X-ray. This is your immediate post-op, and this is 6 months follow-up. You would be able to see absolutely fine. There is no periapical anywhere. There is no pain or percussion. The patient is very comfortable. He's able to eat properly. No sensitivity, nothing. But it's pretty deep, no? Pretty deep, no? Right? How? Then the patient became comfortable. Right? What happened here? Here. See here how it is. And what has happened that has made the patient so comfortable? Right? Think about it, right? Another one way. Again here, you have the buccal cups gone badly. You only have the palatal and the distopalatal cups in place. This all area is absolutely gone. Now, when you are going to do a restoration over here, if you would be doing a amalgam, you would have to go ahead and improve all this, make undercuts. If you are going to do a full crown, you have to involve all this area and you will be losing a lot of tooth structure. So, what we did is, we just prepared that area and we used different adhesion techniques, and this is what we prepared, right? Here you could see these are the steady models. This is the index that we got, and we did some pulp protection here, built up that area with your glass ionomers and composites, made the impression. This is your close-up of the impression, shade selection, fitting it on the cast, and this is how we fitted that particular restoration on the cast. This is your fitting trial that was done in the patient's mouth. The final outcome for this case was something like this. You could see here how we have involved some amount of the tooth structure all over, removed the weak areas. Here there was some decay, removed all this decay and kept the contacts in place, and then given this overlay or a tabletop. This is your X-ray, right? An endogram. Now when we look at an endogram, you can see this tooth. This is A6, this is A46, endodontically treated. Went ahead, did the obturation. I think we used a rotary system here, right? And after we've done this, we remove all this area till your access opening, right? When you look at the clinical, see the clinical picture, here is all the decay out, absolutely, and then we build it up, and here you could see we have sealed all this area with a composite, a flowable composite. Once this thing is sealed, then this area is prepared to receive or ready to receive your endogram. Made the impressions and your endogram ready. So where does this endogram get its retention from? It gets the retention from the enamel, from the inside, and a little bit from the outside. That's your mechanical. But we have to think about something that is more stronger, where we have to also look at chemical adhesion. Okay? Here's your case, we etch it, After we etch it, here's your etching. You can see how the surface has been etched. Now if you see here, I have etched your enamel. The dentine has not been etched, right? So this type of etching, where you only etch the margin of the enamel, is called very good. So this is selective etching. You apply the bonding and then use your flowable composites and you cement it, right? Cure it. This is how it looks lingually and buckily. And this is your case, right? Now you'll do your inlay, onlay, V-onlays, you will do your tabletops, you will do your endograms. Now let's look at your cementation protocol, right? That's the biggest challenge. Your cementation protocol has to be such that you are able to successfully get the restoration to adhere onto your tooth surface or whatever tooth surface is there. Right? So if you see, the biggest challenge that you face here in this dentine adhesion or the clinical is that the dentine structure, you have smear layer and the stresses at the resin dentine interface. So you have enamel, you've got dentine all around here, and this is your bonding interface. This bonding interface is where all your game is, right? If you are able to get this large cavitation around the dental restorations, right? ये सब आपका जाएगा, right? So how you are going to be able to get a proper adhesion, right? Now if you see here how the decay is, the biggest problem that we face in most of the cases is that when caries has gone into dentine, and ever since adhesive resins was implemented in dentistry, the number of problems was increased, especially the post-operative sensitivity, debonding of failure in the restoration and secondary caries. So we have to avoid post-operative sensitivity, we have to avoid debonding, we have to avoid pain and chances of secondary caries, right? So we have to do something that whatever restoration we give, long term is successful, and that is where we come to immediate dental sealing. Immediate dentine sealing protocols for sealing exposed dentine, right? This is one aspect that you guys need to understand very carefully. So immediate dentine sealing uses dental bonding agents to seal dentine at a bond strength that mimics the strength of the dentino-enamel junction at 30 to 50 megapascals. The resin coating is an equally essential step in sealing exposed dentine. Using flowable composites, resin coating creates a secure bond to the tooth, so any failures occur in the restorative material above the resin coating rather than stressing the healthy tooth structure below. So I am trying to first maintain your healthy tooth structure. It doesn't get irritated, it doesn't get sensitive, it doesn't give you pain, okay? And secondary, the bonding aspect, right? So the immediate dental sealing is the application of a dentine bonding agent to freshly cut dentine. The moment you put it to freshly cut dentine during tooth preparation for indirect restoration, inlays, onlays or crowns, and once the chances of the underlying pulp getting irritated from the dentine, some stimuli is reduced. The idea being that when we prepare the tooth for any indirect restoration, a lot of dentine will get exposed, and that exposed dentine will need to be covered and protected to prevent further problems, right? So how do we do this? That's where you're going to do your immediate dentine sealing. Immediate dentine sealing is an important step in a bonding protocol that will help you increase the bond strength, decrease the bacterial leakage, less gap formation and reduction in the post-operative sensitivity, right? So the IDS, as it is called, has a positive influence on the tooth structure preservation, patient comfort, and long-term survival of indirect bonded restoration. IDS can be applied in posterior and anterior areas. It is also helpful to do IDS prior to root canal therapy, as it can help prevent dentine from contamination of the endodontic materials. And immediate dental sealing should be applied to everyday dentistry. I am not saying this. There is a whole lot of evidence. This is a systematic review in the Journal of Prosthetic Dentistry, which talks very, very categorically that immediate dental sealed indirect restorations have fewer clinical complications and higher success rate and survival rates than those delivered without dentine sealing. To avoid post-operative sensitivity or reduce its intensity, dentine surfaces should be sealed immediately after preparation. More long-term randomized control trials are required, which I am sure now Madam will start, right? Because I know the amount of research that is done in ITS is really wonderful, right? It's very Madam sends a paper to refuse the papers, right? Because she does such a lot of good research. So when do you do this immediate dentine sealing? Okay, freshly cut dentine found only at the time of tooth preparation. That is the time when you've done before the impression. Immediately when the dentine is freshly cut, it is advised to perform your immediate dentine sealing after tooth preparation and before impression taking. That's because the dentine bonding agent will add some thickness to the preparation. क्योंकि वो थोड़ा सा उसकी thickness आएगी. So जो आपकी final restoration की जो seating होगी, उसमें फिर loose नहीं होना चाहिए. Okay, so that's the reason why about 40 micrometers thick it will become, and this would interfere with the seating. Whenever an area of dentine has been exposed during tooth preparation for indirect bonded restoration, local application of a dentine bonding agent is recommended, right? So you can play around with the dentine bonding agent. You can also play around with the flowable composites. Okay, now essentially look at this particular paper again in the JCDE, right? This is by these guys from Brazil, where they have shown us how using your confocal microscopy, how your bond is, and also the SEM, a standing electron microscope, showing the advantages of then marginal sealing with the help of the dentinal sealing, right? Now, the immediate dentin sealing again has a lot of advantages: contamination of saliva, bacterial leakage, and provisional restorations is prevented, and the bond strength is good. The pre-curing of dentin bonding agent again improves your bond strength. When the dental bond is allowed to develop without stress, that is the composite layering and shrinkage occlusal forces, the restoration adaptation is significantly improved, and patient comfort because of the reduction of post-operative sensitivity, right? Again, this also increases the retention if it is used in full crown, especially when we are dealing with tapered preparations. Its ability to use light pure dentine bonding agent and separate conditioning of enamel allows the practitioner to focus on the bonding to dentine separately and enamel separately. These are two aspects: enamel ki bonding or dentine ki bonding, and then all of it has to stay together, right? So if you look at your restoration, you have your restoration surface and you have your tooth surface, right? So you can prepare the restoration surface, the cementation side of the restoration, as well as the tooth surface. So when you are doing a restoration, you need to clean that inside thoroughly. You can use your sandblasting and then followed by air. So once you use a sandblasting and followed by air, this area gets clean. Right now, never use it on the occlusal surface, only on the impression area or the area of the cementation surface, right? So here you need to understand another terminology which is called peripheral seal zone, which is the 2 to 3 millimeters of tooth structure, enamel, BEJ and superficial dentine, in which complete caries and crack removal is indicated. The dentine and enamel junction, complete caries and crack removal should be carried out 1 to 2 millimeters inside of the position of the BEJ. So here you can see you have this green area as the superficial dentine, the yellow is the inner caries, so affected dentine, and the red is the outer caries, so the infected dentine which needs to be taken out. Right? Now, once you understand this peripheral sealing zone, you are left with three types of etching patterns or techniques you can use. You can use self-etch, which is you don't use the etching. Straight away, if you use our beauty bond, which is the 7th generation, you don't need to etch. Straight away, you can apply that all over the dentine. If you are going to not use this and you are going to use the two-step etching technique, then you can use selective etching, where you will only apply this on the outer surface, which I had done in one of the cases. Or you can use the total etch, where you apply it on the enamel and the dentine. Right? This is the same thing depicting for you. Right? So you can use any of these depending on the case. So your tooth, you etch it, sandblast it. Then you can use either the selective etch, the self-etch or the total etch, and then here you apply a bond which is to be applied in 2 layers followed by a flowable, right? So here you could see we sandblast the tooth structure, get it totally clean, then we apply 2 applications of the bonding agent all over the surface. After we've done that, we apply flowable composite and then we cement your restoration and cure it. So here you could see this video will show you. Yeah. How it's done. You first clear that area, get your isolation in place. Apply your bonding agent twice, cure it every time. Second layer, cure it. Then you take your flowable composite and place the restoration onto that and cure it. This way, you get your cementation protocols done. Would you like to speak for a while and then I take on the next bit? Yeah. So you all can take a break from me for a while and I'll come back again. Dr. Mohan will take. So I will be happy to take a lot of questions. We are trying to cover everything in bits and pieces till the whole story will come across to you. Yeah? Right. I'll disconnect that. Audible? Do you understand? It's a little too much, right? Now, like I told you, last part is easier, but when we go ahead, it's going to be a little more subject oriented, and then there's going to be a lot of science behind what we're going to talk. I've tried to make it as simple as possible. But the point is, if you don't understand the theory part of it, it becomes very difficult for you to go for the practical part. Okay, so the little bit of theory has to be there when you're going to work towards the practice. Now, if I'm going to ask you a question, when you write your case sheets, right? Do you write it as root canal followed by crowns? What do you write it as? After root canal, what's the treatment option do you give? Pardon? Prosthetical? Let's assume you're all clinicians now. Forget that. You are in college. So now you see a patient. The patient comes to you. You've decided that you want to do a root canal. And then how will you take it up? You will say, अभी root canal करना है, उसके बाद cap करना है. ठीक है? Okay. So this is the language which you will talk to your patients. Why? Why? Because you are comfortable. It is not because it is right. And you are comfortable because why? You all know crown never breaks. And what breaks? Tooth. So if the patient comes back, what will you say? My crown is intact, your tooth is broken. So there is one self-satisfaction that if something goes wrong, I still have a probability to blame the patient. But that doesn't work. Okay, nowadays there is one thing called Google. God, okay, it gives enough and more information which are completely wrong to the patient, so they can have enough arguments to happen. Now, when you shift from mechanically retained restorations to bonded restorations, there are few things which you should understand and there are few things which you should forget. Okay, understanding is easier, forgetting is very, very difficult. The first thing what I want you to forget is shape. Forget all your conventional preparations. There is no conventional preparations for your indirect restorations. The names will be fancy, like what Shishi sir has told. You will have fancy names. It's like our dress. We will be wearing a shirt, but then the shirt has so many names, but technically for us it is shirt. And for girls you have salwas, and on that you have so many names, but technically it is just a salwa what you are going to wear. And down south when we have sari, and that sari has so many names which I have no clue about. For me it still remains it as sari. So for indirect restorations, if you stick on to your regular preparations, it will not work. So that's the first thing which I want you to forget. Okay, only one thing I want you to forget is, forget the shape. Second, what I want you to remember is the biomimetic principle, which means you are looking at bonded restoration. So which means the principal part of any bonded restoration is you need to stick something onto the tooth surface. So which means you should have tooth surface and then you should have something to stick onto it. So you have to remember these four principles. The first one is you have to maximize your bond strength. Okay, so which means you don't have an opportunity. You have to work with your limited resources, whatever you have, which means you have your tooth, you have your bonding agent, you have your handpiece, and you have your skin. With that, you have to maximize your bond strength. Second, whatever bonding you have done, it has to stay for a very, very long term. We don't want it to break within a day or two. We want it to stand for a long. Have you seen amalgam restoration staying for 30 years, 40 years? Yeah? Why do you think it stayed? Was it bonded? No. It was never bonded. It was just staying there unimaginably good. You know why? Pardon? Expansion happens. Okay. No. No, that's not the reason. The reason is, self-sealing. Okay, that's all the property of amalgam. But why did it stay? You knew the basic principle when amalgam was brought in. Another principle was brought in, which is called as extension for prevention. Have you heard it? So wherever fissures were there, whether caries was there or not, you extended it and you filled it. So what happened? There was so much undercut over there, the amalgam restoration started to stay, and then you had self-sealing ability, expansion of that, and two, our habits towards food were very, very different those days. Okay, now the concept for extension of prevention is gone. Right now we are into minimal invasion. So which means we don't want to extend, we want to do only minimal. We are not looking at mechanical retention, we are looking at bonding. Correct? So first thing, maximize your bond strength. Second, whatever bond strength you have done, make it to stay for a very, very long time. Third, increase the vitality of your pulp at any cost. Like I told you before, just because you know to do endo, don't kill it. And for PGs, masters in endodontics means you are not supposed to kill, but you are supposed to save. It's the reverse. Don't think that after finishing MDS endo you have all the ability to kill. You should have the ability to save the given tooth structure. Last part of it is to decrease your residual stresses which happen because of bonding, because of composite layering. You get these principles? These are the four principles which you should always remember when you are going into indirect bonded restrictions. Now, these four principles are governed by two protocols. One is your bond maximizing protocol, two is your stress reducing protocols. Now, when we go to stress reducing protocols, there is a whole lot of things which you should do when you are going to do your indirect restrictions. Okay, so the first one is always use indirect or semi-direct. That's what we are going to do. Second, decouple with time. This I have taught you last time. That is, when you apply your bond, you have to give enough time for the bond to mature. You remember how many minutes? Somewhere between 5 to 30 minutes. And imagine 30 minutes, what all can happen? 5 minutes itself, lot many things can happen. So you have to allow decoupling with time to happen. 3, whenever you are restoring your tooth, always restore them with minimal composites laid in a horizontal fashion. Okay? Why? Because you are going to reduce your stresses which develop within the tooth structure. 4, use slow start, that is with your light cure part. Then use dentin replacing composites which have shrinkages less than 3%. All your composites have less than 3%. There is only one composite which has less than 1%, is Shofu's LS. It's called as low shrinkage composite. Okay? Then you have, when you're restoring your pulp chambers, remember this, always use glass ionomers to restore your pulp chambers, or use chemically activated composites, or use dual cure composites which can set inside your pulp chamber. Now, why is this restriction kept there? You all know the terminology called as C factor, correct? So configuration factor is the factor to be bonded to the non-bonded surface. Now in your pulp chamber, do you have enamel? No. But what do? We take composite, we etch the pulp chamber, we fill the chamber with composite, and we light cure. Correct? Do you understand how much of stresses will that give? Why? Because it's a classical class 1 preparation.
And the dentine, do we know any idea about the dentine in palm chamber? Coronal dentine itself is a havoc for us. Pulpal dentine is worse. So, whenever you are in pulp chamber, always remember, in a clinical setup, like I said, glass enemas will work wonders. Just use glass enema, place it there, allow it to set, then work on the coronal aspect. Remove dentinal cracks when and where it is required. Initial thought process was that we have to run behind the dentinal cracks wherever it is present. But then now we have realized more we run, more we cut, more the tooth strength reduces, and then it acts as a fraction. So think logically whether to cut or to not to cut, and if you have to cut, how much you will cut. Okay. Then limit the cusps thicker. This is not about the preparation of your tooth structure I am talking about. This is the height of the restoration which is going to come back to you from the lab. Don't think that if you have a longer inlay or a thicker inlay, it will stay longer. No, it's the reverse. Okay, anything more than 2 millimeters, compression goes, tensile forces come into picture. Any restoration which can bend will fail when you bond it. Why? Because your hybrid layer, you remember this hybrid layer, right, is stronger only in compression. On a tensile force, they will fail. Okay, so don't think that I have kept 4 millimeters of thick inlay, it is going to stay longer. No, 2 millimeters stays more than your 4 millimeters. Is it clear? Then that is your stress management protocols. When you come to bond maximizing protocols, the first thing is you have to establish a caries-free peripheral seal zone. That's what Dr. Shishisa told you, that 2 millimeters of caries-free. Invariably, the peripheral part of your preparation should not have caries. Can the center part have caries? Yes. Can I allow a little bit of caries to stay there? Of course you can do it. Okay? Studies right now say that you really don't have to remove complete caries, which doesn't have a peripheral communication, because the bond, the materials, whatever you use can cause mummification of that particular caries, and then your restorations can still stay. Clear? Second, air abrade the surfaces. Now slowly we will move away from etching to self-etching, and then we will come back to air abrasion of surface. I will show you case-wise. Bevel where it is required. Posteriors we don't bevel, anteriors we do bevel. Remember that. Next, deactivation of metal matrix proteins. You can use with chlorhexidine 2%. Place it inside the cavity for a minute or so that it prevents the deactivation of matrix metalloproteins. Now, is it done routinely? No. Clinicians do it? No. Do I do it? No. But then theory says you can do it, because why? These metalloproteins cause degradation of your collagen. Now, will it work? That's what research says. But in a clinic, will we spend so much of time on it? If you ask me, the truth is no. Now, the funny part over this is, this happens in a collagen which is alive. Now, in a root canal treated teeth, what will you do? The collagen is not at all alive, right? It doesn't have any support systems for it to make it alive. So think about it. I won't give you the answers. I can give you the answer tomorrow. Okay? This is for PGs. Now, what you have to deactivate, I told you how we will deactivate. Then employ gold standard bonding systems. All systems are gold standard. The point is, now, when bonding was started, when composites were started, there is nothing called bonding. There is no bonding. There is only resin which was placed and light cured. Then they figured out it started shrinking. They didn't know what to do. Then etching came. Then bonding came. Then now The point at that point of time was to stick the resin to the tooth. Nobody understood what happens in dentin, what happens in enamel. Now when bonding towards enamel was done, it was easier because it never degraded, it never collapsed, never disintegrated, nothing happened. Now when dentin came into picture, you all have studied that dentin has collagen, and then when you etch and then when you dry, the collagens are like noodles, and then this noodle shrinks, and then you don't have bonding to go in. That was good till I studied bonding. Okay. Then they realized that when bonding goes inside this collagen, collagen degrades. Okay, after some time. And then when it degrades, what happens to the bonding? So right now, all your bonding systems are targeting again your hydroxyapatite. They are not targeting the collagen. If you want to target the collagen, then the bonding system should have a specific agent which will form a chemical bond to the collagen. Do we have? Yes, we did have aldehyde based bonding agents, glutaraldehyde based bonding agents, but right now they are not in market. They are not in market. So right now most of the bonding systems are targeting the hydroxyapatite which is present on the collagen. Now why am I explaining all this is when you etch, what do you remove? You remove the hydroxyapatite. So when you etch your dentin, what happens? The hydroxyapatite crystals which are top of the collagen gets removed. Now now bonding agents are targeting the hydroxyapatite, but technically we are using acid to remove the hydroxyapatite. Now can we do something instead of this? This is when your air ablation comes into play. Okay, so now you understand why air ablation I am talking about. Okay, so can we get away without etching? Yes, you can. Why? Because we are trying to maintain as much of hydroxyapatite. And why are we maintaining it? Have you heard the word called 10 NDP? In bonding, all your 10 NDPs target your hydroxyapatite. They don't target your collagen. Okay, got it? So that is why you have to have air ablation. Then immediate dentin sealing, that's what Shishi sir has told you. Why, how, I will show you in a case. Resin coat has to be done, and finally achieve deep margin elevation. Okay, when we do all this, we have a complete thought process done. After this, no writing. Okay, these are only cases. Now you get relaxed. Now, technically, you have a substrate, that is your tooth. You have to modify the substrate. Why? Because it has to receive a restoration. Now, when you combine all these three together, that is when you have something called as a mono block, which means the tooth, the restoration and the bond all together work as a single unit. So when you bite, the forces are transmitted all along to the tooth surface. Now if you don't do this, each one will work on a different principle and then they will break out. So we don't want that. Now, if it is substrate, the substrate can be vital, the substrate can be non-vital, correct? And then in that substrate, what will you have? You will have enamel, you will have superficial dentin, then you will have the secondary, tertiary, reparative, and then the pulp chamber in case of a non-vital. Now, when I explained to you about the bonding protocols, I was telling you about all this in mind. So, in all this, what will you maintain the most? You will maintain enamel the most. Second part of it is the superficial dentin, deep, secondary, tertiary, reparative. Do we have a clinical assessment towards it? Which is what? No. We don't have. If I ask you what is infected, what is affected, you will tell me. But if I ask you to show me, nobody has any idea unless and until you take the histological section, send it to the lab, and imagine telling this to a patient. Okay, I'll send it to the lab, I will find out which is affected, which is infected. we're a little crazy. Okay, so this part of it becomes questionable. So that is why I am saying maintain enamel as much as possible, because that you can never go wrong. So that is when your peripheral seal again comes into picture. Why we are so much bothered about the peripheral seal zone, because the rest is all, you can use dyes, you can use stains, you can use fluorescence, you can have goggles which let you know where you are, and all these are expensive. But trust me, if you want to use fluorescent light over that fluorescent light alone, globals cost around 3.5 lakhs. And is it worth it? No. Absolutely not. And if you have a microscope from Carl's, that unit is 7 lakhs, and one light goes off, those fellows don't give you even replacements. Another 7 lakhs you have to pay. For what? To figure out which is affected and which is infected dentin. So might well you can play with enamel, keep the enamel intact, and then the rest part of it we can work towards it. Okay? So this is how the substrate. Now, second part is, I told you, is modifying the substrate. Why should I modify the substrate? Yes, you have to modify because it has to receive something and it has to support something. The first part is physical, that is to accept, which means tooth has caries. You have to know how you are going to remove the caries. Why? Because you are going to apply something on top of it, so that you are physically changing that shape of that given tooth structure. Second, structural. Now, you have added composites on top of it. Structurally, you have to modify it so that it is in a proper shape, so that when you put some restoration on top of it, the restoration will also stay on top of it properly. Last one is chemical. This physical and structural change should be so good that when you treat the tooth chemically, it can accept to that chemical change, minusing which none of your indirect restorations will fix on that particular tooth structure. You got it? So physical is nothing but you should learn about removal of caries, you should learn about immediate dentin sealing, then you should learn about resin coat and composite layer. So that is what is physical. Structural part is nothing but you should learn how you will prep that tooth structure. There is no definitive preparation for a given tooth structure. The last part is how to cement the indirect restoration on top of that given tooth structure. Is it clear so far? Okay. The last part is restoration part. This can be the inlays, onlays, overlays, veneer lays. You can call it any name you want, and that can be of any material of your choice. You can choose ceramics, you can choose lithium disilicate, you can choose zirconia, you can choose indirect composites. But today we will teach you how to do an indirect composite yourself. Okay, so it's easy for you when you go back to your clinical practice. Then how much do you charge here for an indirect restoration? Outside in clinical practice, give or take. How much? I won't ask you how much can you, because you guys can think now. How much do you charge? See, I'll tell you, the lab charge for an indirect inlay is somewhere between 3,000 to 5,000, the lab charge. After this is your charge. So give or take, you should charge at least 15 to 25,000 for you. Now, when we use indirect composites, the lab charge is 800 bucks, and it is as good as lithium disilicate, close to. So you work towards how you're going to do. Is it good? It is extremely good. Okay, and my guess is give or take another 5 years, you'll forget crowns completely. Completely to go off, and it will all be with your bonded restorations. Now, okay, what do you see? single tooth, correct? There is a cavity. Now, I have removed the cavity. Can you give me an option of restorations for this final restoration? First, let me know whether it is direct or indirect. We are taking indirect, obviously it will be indirect. No. See, when you are going to choose the tooth, whether it is going to be direct or indirect, the easiest way for you to figure it out in a proximal aspect is to check the width of that cavity. If the width of the cavity crosses your contacts, go for indirect. Direct will fail. Give or take, after some time, it will fail. There's so many times you do a class 2 and after 6 months, 7 months, the patient will come back to you, you will see the restoration popping off and the cavity still remaining there. The reason is it's a too broad a contact. 2. Whenever you're doing your cavity preparations, divide the teeth into 4 halves. Okay? Center, you draw a line and divide it. Give a score of 1, 2, 3 and 4. 1 will be the maximum area where there is cavity, followed by 2, 3 and 4. Always remember in your preparations, 3 and 4 will have the least amount of preparations, where 1 will have the maximum, 2 will be less. So which means when you start your preparation, you will not think of crowns. If not, what will happen is you will take a burr, run it 360 degrees. Okay, slowly I'll teach you how to do it, but just remember, cross it off like this, 4 halves. In this case, this half will have score 1, score 2, score 3, score 4. So my prep will only remain to this box of the preparation and very minimal on the other side. So what happens is only 1 half of your tooth will have prep, and then will this restoration stay for a long time? It will stay for a very long time. Minimum failure rate is 15 years. Only then you can think of failures. Okay, and if I do a direct composite, there is a good chance that it will fail within 5 years. And if you have followed all protocols properly. Okay, so now, how are we going to go about this? You see that after preparation, that entire part of the tooth is completely still not touched. So which means I have enough area for me to save than to prepare. So you have to start thinking in this angle. So first is physical. In physical, what I said, removal of caries, maintaining vitality, retaining marginal ridges, crossing ridges. If you have to do deep margin, you have to do the deep margin at this point of time. So we will think of all these things when we are doing the physical alteration of a given tooth structure. We have all been taught this. Right now, we are not going to do this. Okay, this is not what we are going to do anymore. So, scenario 1, buccal. You have caries. Ideally, what we will think? We will think we will do root canal, followed by crowns. But that is why you are not here. You wanted to think different, you wanted to learn different, and then you wanted to be better dentists, right? So, now, removal of caries. How will you remove? We all spoke, we use diamonds, we use spoon excavators, and somebody said smartly smart burrs. Okay, but then smart burrs, expensive, we will tell, but we will not use them. I'm being very practical and honest to you guys, okay? Only then I can reach you. I can tell that you can use chemical methods of removal of caries. I can show you, but in clinical practice, none of this happens. the first instrument which comes out is the round diamond. Okay, other than that, nothing else will come. And if you are an endodontist, you will sleep with the round burr with you. I am telling you. If you like your boyfriend or the round burr, you will anytime pick round burr. You will never go back to anything else. So, now, when you are going to remove caries, what are we going to look for? We are going to look for the peripheral seal zone, which means the periphery of the cavity has to be fine. Now, what does this mean? It means don't take the diamond and go into the center of the cavity. You get it? First, you will remove only the periphery. We are taught to take the diamond and we go center of the cavity to remove the caries. So, second point to remember is center is last, periphery is first. So, if you take your diamond and if you go center first, there is 99% chance that you will hit the pulp. For sure. Then you will say, yeah, I am correct. Why? Because you go directly into the center. Don't do that. So take your diamonds, take whatever you want, even your spoon excavators, don't put it in the center. You put it in the center, it's the softest part, you will destroy it. Isolation, burr, periphery first. So when you start removing the periphery, you see that the periphery is completely devoid of caries. Don't use your stains at first time itself. If you stain, everything will look pink or blue or green. First, prepare the periphery off, then use your stains. When you use your stains, allow these stains to stay there for minimum of 10 seconds. Only then you have to wash them. Now, once you wash, you will have stains like this. This is fine. Wherever you have peripheral staining areas, take your diamond and slowly remove it off. Okay? So now this is the prep we have. This prep is completely not in any form, any shape, and you cannot put anything inside this area. But this thing, what it has enamel, it has good dentin, and it is the right time to seal. Always remember, fresh cut dentin is the best dentin for you to bond. Okay? So now, when coming to bond, what I told you, I said I will see how to air abrade. So this is what is called as air abrasion. We don't etch. Okay? So you take the air abrasion, you run it for 10 seconds on the tooth surface. So when you run like this, it is made up of aluminum oxide powders. Okay? It is 50 microns and it requires 2 bar pressure. The same pressure what your handpiece was. So you can connect this to your handpiece nozzle and then cut off water, and then when you air abrade, this is how the surface will look. Is this good enough for me to bond? It is fantastic for me to bond. Now, after this, if you feel that you are not comfortable, you can etch your enamel separately if you want. Is there an option? Yes, there is an option. Can I use it? Of course you can use it. So you can etch. But then the advantage of the bonding of what Shofu has is, it is a self-etching system. So which means you can add a braid, you can apply it on the tooth surface, you don't have to scrub it as actively as before. Okay? So you will apply a little bit of scrubbing is required. How long will you do? Is 30 seconds. Okay? And then remove the excess bond, after which you will light cure. So this is how it goes. So I have done the apply bonding, remove the excess, light cure. This is what is called as immediate dentin seal. Understood? Now, when we do the immediate dentin sealing, the problem is your capillary pressure within the dentin is going higher, and that will push the immediate dentin sealing out. So to protect this immediate dentin sealing, what we do is called as the resin coat. So the resin coat is done to protect your immediate dentin sealing. So second coat, Right here. And this is what is called as resin coat. What you're seeing now, this is called as an injectable. So you apply it, very thin layer on all areas. And after this, you wait for 3 to 5 minutes. So now this resin coat plus your bonding all put together will form your immediate peeling. After 5 minutes of waiting, then you add composite on top of it. So you understand? So this is exactly what is called as physical modification of a given tool structure. Composite, like this, and then you finish it off. So is it clear so far? Physical part of it. Now, second scenario. This is on the buccal surface you saw. Now let's see on the proximal surface. Now when you see so many cases you have seen like this on the proximal surface. So after caries removal, always look for enamel. If there is an enamel, please preserve it. Now, how can I see this? Is it easy for me to see in naked eye? No. Should I have magnification? Yes. Some form of magnification. Please learn slowly. So you can use your loops, not expensive at all. You can get those loops. Loops are wonderful, and if PGs have microscopes, please start using them. Okay. That enamel will change your treatment plan, treatment objective, and the number of years the restoration is going to stay inside the mouth. So you have enamel, you have dentinal enamel junction, you have superficial dentine, you have deep dentine, and we have effective dentine. So like I told you, the periphery 2 to 3 millimeters is completely devoid of caries. There is no caries at all. Once this is done, stain. So staining happens only after removing your peripheral caries. Don't take the stain and then put it immediately when there is a cavity over there, because it will show you wrong. So remove, stain, check, wash. Do this process at least 2 to 3 times. Okay, not at the first go. First go, if it has nothing is there, it's fine. Second, if it is there, remove it, re-stain it. At least you have to do minimum 2 to 3 times for you to be sure that you have removed all the caries in that particular area. Once this is done, this is what is called as selective etching, which means only the periphery we etch it with acid, and then you etch bond. You go ahead, like I told you, you have beauty bond. This is set. It has a self-etching system where you don't have to etch, but it is better when you go in the posterior to etch peripherally so that it's easy for you to bond. And then go ahead, finish it off. Now, in this tooth, if you see, you have a cavity only in that area, right? It's fully filled. But then you had a glass ionomer on this thing. You're able to see the glass ionomer filling. Now, options of preparations are, ideally what will you do? You will take your handpiece, you will do a class 2 prep, you will cut in between the tooth surface. Now, remember these two things. There is something called as crossing ridges, okay, and there are something called as sub-crossing ridges. Sub-crossing ridges, this is for PGs, remember this, they are called as raised ridges. Okay, so they are beneath the level of your major crossing ridges. So when you cut a tooth for a class 1 or a class 2, you are cutting these ridges completely off. So which means you are creating two independent structures which, when a force given, it tends to separate off. Instead of that, if you are going to have the same structure like this and prep it on top of it, you will never make that structure open up like this. whatever forces are given, it turns into, okay, it turns into, seriously, it turns into compressing. Okay, so don't go in between. So, if you see this prep, I have not gone inside, whereas I have prepped only on the surface. I will show you the side picture. See, that is the oblique ridge, one cusp. That's the filling. That's the remnant cusp which you have here. That's your glass anodes. So why I am not teaching you the perfect picture for doing a preparation is, if I teach you one shape, you will continuously do the same shape whether you like it or not in all your tooth surfaces. But what I am trying to tell you is, divide it like this. So whenever there is a crossing ridge, don't cut it half. Run over it on top like your anatomical tooth preparations, so that the prep is like this, and when you see it on the side, are you able to see how much of tooth substance that you maintained? Okay, so that is your occlusal preparation. This becomes your buccal, that side is your palatal, and all my preps are in enamel. There is no dentine except for the center portion. So if somebody asks me how long will it stay, this will stay for a very, very, very long time. Got it? So this is one prep. Now, so you saw two cavities. One you had caries, second one you had caries. Now this one is a premolar. Those two are big too. Now in this premolar, what do you see? You see a cavity which is filled, correct? Then can you see a discoloration? Sir, do you have a pointer with you? Just that, this one. So, are you able to see a discoloration here? Okay, so you have a filled cavity here, you have a discoloration. Now, how will we check this? Take a microscope, change the angulation. Are you able to see a white speck over here? Okay, usually this white speck denotes that there is caries, active caries in this region. The first diagnosis for you whether there is caries is there or not is not black. It is actually white. Why? Because of demineralization. Okay, so you check for that. Now, in this case, what you do is you apply your disclosing agent or caries is detecting that. And when you wash, this area will pick it up. You're able to see that? Now, this is all fine. But premolar is a small tooth, correct? Very, very small tooth. Now, how will you do? Already one half of the tooth is gone. If I drill on the other side, other half will also go. So what is left is one middle part. So usually what we will do is we will do something called as an MOD. You can't do MODs with indirect restrictions. If you do an MOD, it means you are taking the premolar, cutting into two halves, you're breaking the crossing ridges, you're breaking the rayleigh ridges, and then premolars are two sharp cusps. And the lower premolars, when they hit, this will work separately, this will work separately. So what will happen is, there is a good chance for your restorations to fail. The thought process, what has to change here is simple. We do prep. Preparation is done because caries was there. You see that the stain is still intact. But slowly, we will change the preps like this. We will not cross over. Instead, we will encircle. And when we are encircling, you see this margin? This margin is always maintained at the height of contact. Okay, don't take it below the height of contour. And this margin, try to keep it at the level of contact or above the level. This is not under your control. This is under the control of KD. So if it goes down, let it go. It's not a problem. But when you come on the parietal surface, okay, keep it as high above the level of your height of contour. Now what's the principle behind this is your enamel rods. Your enamel rod's orientation changes from the cervical to the occlusal surface. So which means at the cervical level they are at an angle downwards. As it comes towards the middle part, it is 90 degrees. And as it goes up, it becomes straight 90 degrees. Okay, so what did I tell you? Even enamel rods behave the same way like your hybrid layer, which means they are good at compression, bad at tension. So keep your margins in such a way, wherever the margins are there, the orientation of your enamel rods should be like such a way that when a force is given, there is compression. Okay, so if you see in this, here their enamel rods will be like this. So when there is force, there is only compression, there is no tension. Likewise, when the enamel rods are coming up, it is at 90 degrees straight. So when a force is given, here also it will be only compression and there is no tension in that area. But now, is this enough? No, this is not enough. A little more you have to understand is, these enamel rods, if left unsmoothened or unfinished, they act as nidus where the pressures can cause further fractures. Okay, so having enamel is one thing, finishing enamel is one more thing. So all your preps have to be finished or technically have to be polished to an extent wherein they are smooth. Okay, so this is the second point which I want you to remember. So whatever preparations you do has to be finished or polished when you are doing your indirect preps. Don't leave it as a rough surface. Don't think that leaving rough surface is going to improve my retention. It will not help to improve your retention. Why? Because if you leave it like this, see, this looks fine from the occlusal surface, but when I turn it, you are able to see jagged margins everywhere, and you see this is enamel still. I have not cut through. You got it? So this enamel on top, on the sides, all this gives protection to this tooth surface. Okay, but this part has to be prepped, and when you finish and polish, this is exactly how your preparations should look. So above the height of contact, no, it's not gone above the, it's just placed above the height of contour. Here at the level of contact, palatally when we see, it is at the palatal surface at the height of contact. Okay, so this is exactly how the tooth preparation has to be there. Now, after doing the tooth preparation, what will you do? Now we have done the tooth preparation. In this case, this is aerabrated, and then you put your bond. So when you apply the bond flows. This forms your immediate dentine seal. After this, you will apply resin coat, and then you will finish your restoration, which means till this time it is only preparation. Once this is done, then we start with our impressions. Is it clear? You understand how to think for one molar, for a premolar, or for a different tooth structure. So MOD's concepts go off, you don't cut through, and you slowly have to forget the designs what you have in your mind. Now this is done, crown cemented. Now when you have proximal and occlusal, this is, I call it as restoratively driven endodontics. Okay, we have to do endo only based upon restoratively driven, not endodontically driven restorative, which means you do endo and then you baad mein dekhenge. No. Even before you start endodontics, you should know what kind of restoration you're going to give. I am not against endo, Okay, I'm really not against it. I love endodontics. But the point is, what we do is most of the time we do it wrong. Now, there is a picture. There is an axis preparation. One is here, one is here. This I did, this somebody else did. Okay. If it was me, I wouldn't have drilled the hole here. Why? Because I know these two cusps are connected. There is a huge filling here. I would have just removed the filling, I would have maintained this tooth structure over there, and then I would have proceeded. Okay, that is what I am trying to tell you. Any crossing ridges, any marginal ridges, don't cut. If you cut, you lose 25 to 35% of strength just like that. Whether you do endo or not is secondary. Just by cutting, you lose it all. Okay, so don't do that. Now, like I said, I love endo. I do endodontics, but I don't teach. Why? Because it is not in my passion to teach. My passion is fully restorative. So when you do proper endodontics, everything comes in. You see the floor, sealer from one canal to the other, one fin to the other. So one place you inject, it comes in the other way. All that is nice, but this niceness is all gone from it. It is out and dusted. Initially it was all wow. Now it is boring. It does happen every time, but then it is boring. But if you see, why I showed you this picture is, you are able to see two canals here, but there is another canal here, but the tooth surface is still there. You are able to see that? So when you are planning your axis, always remember that restoration precedes your axis preparation. And we are in an area where we don't have to have straight line axis. Okay, you get that? So much of metallurgy has improved. You can even bend the file, magnify files, then put it inside and then take it out. So after some time, you just have to name the file. I think it will go inside clean for you. So we don't have to worry about that. So once you finish off endo, now if you see, this is the axis, this is the restored part. So this much of tooth I have in my place, right? If you see here, there is axis done by somebody, and then you have a filling. Now the part here is, interesting part with this is, it's simpler. You do ideas, you go ahead with restoration and you finish it off. Now when we go to the premolar, GP is here, but when I turn and see, there is a cavity here. Okay, so which means either he should have entered the other side or you should have never done this. But now it's done. So what happens is, this part is completely separate, this part is completely separate. Now immediately what we will think is, we will put a post, we will stabilize the tooth structure, and then we will cut and we will give a crown. And if you do that, trust me, 6 months this teeth will break. For sure. Okay. Now, what do we do in these cases is, same principle. Look for caries, remove it here, but if you stay still, I am maintaining the marginal ridge. I have not taken the marginal ridge off. Stay in it, remove it off. You see this marginal ridge? I have kept it still intact. I have not taken it off. So there is restoration here. This restoration is removed. I have a huge lingual cusp and practically barely sitting buccal cusp. So I don't want this to be removed. So then you go ahead, you start your restorations, finish it off layer by layer. Create the peripheral seal zone, and all this under isolation. Okay? And how you get this isolation is up to you. If you learn rubber dam, it's the best. If not, please use Teflon tapes, pack it up, cheek retractions, and cotton rolls. Isolate, do your deep margin elevation. What you see here is a total Mayer band. Cut the total Mayer band into half, put it in your total Mayer, push it underneath your gums. Okay, so it will go below the contour and it gets nicely snugly fit. Otherwise, you can use hi-fi systems like Garrison's. Each band is roughly around $1,500, and only for the band is $1,500. So which means just for placing the band, you should charge bare minimum $1,500. So the better is total pay. Cut it into half, place it there, and go ahead, restore it, build it. Now once once it is built, you have a form. So now what I do is the same way, buccal cusp, height of contour, proximally I go down, lingually above the height of contour. So what happens is this whole unit becomes a single unit. Any pressure, they will never open up. Okay? Understood? Clear? Now when you look at the molar, one cusp only is prepped, the rest is left. So which means this amount of tooth is still there. And if you see, this crossing ridge is still maintained. I have not taken off the crossing ridges. So always maintain your crossing ridges and your sub-crossing ridges, which are called as your Rayleigh's ridge. So now when you finish, that is how they look. Margins are clear, tooth preparation is fine, and if you see, enamel is maintained here, 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 everywhere it is enamel. So there is absolutely no chance that anything can go wrong. Scan, this is a scan model, and then when the crowns come, they look like this. And this is from with ceramic. Okay, and this you will have a demonstration today. So you will understand how you can make your own crowns and then how you can fix it. Okay, with this we will take a break now. Okay, any doubts? Please ask if you have doubts. Any doubts so far? It is okay to ask questions, you know that.
And we've crossed that you don't have, if you're scared of me or you don't want to ask, nothing like that. So you can ask questions. If you feel something has to be told again, I don't mind repeating it because this is quite a lot for you guys. But when you start doing it practically, it becomes very, very easy. Very easy. Any questions?
So the preparation has to always be below above the height of the contour, both for the parallel as well as for the molar.
For premolars, it is always there. We keep it at the height of contour because see, we are not looking at full crowns over there. Okay, we are looking at restorations which can convert forces to compressive. And then two, the amount of clearance which you will require for the ceramic is 1.8. 1.8 mm of clearance is more than enough. And you can take out a force of roughly around 400 psi. Lithium disilicate is 600. Amalgam is 300 watt. So all you require is 2 millimeters minimum space. So if you work from this area to this area, I will have 3. And from this to this, it goes to another 3. So all I'm looking for is 1.8 to 2 mm of clearance. On the occlusal surface, you see it's more or less flat, or it will take the exact shape of that of the premolar. So once I get that, and I get that clearance, and it is easier. The second part with premolars are, there is no intercuspidation. Your lower premolars will always hit at a single given point. So if you can clear it off, you will get that space. You don't have to set it flat. Okay, so low premolars usually hits only on the marginal ridge or on the marginal fossa. It can be mesial, it can be distal, never in the central one. So if that area alone you can take off 1.8 and you maintain a higher surface in the other area, it's still low because you will have to get it. So which means your tooth preparation is not standardized. That's why I said, please forget the shapes. So which means one area will be slightly elevated, the other area will slope down. You don't have to have those flat cuts or nice preps. No, don't. N-NDP bonds to hydroxyapatite. More than that to the collagen. Now when you etch dentin, what happens? You remove the hydroxyapatite. So we don't want the hydroxyapatite to be removed. So how you can do that is by aeration. So you roughen the surface. At the same time, the hydroxyapatite is not removed. So when you bond, this bond can bond with the hydroxyapatite. Any other questions? For aeration, 50 minutes. Aeration is done once you do the cavity once, and when you leave. See, usually capillaries are not given on this because you've sealed it completely off, so you can send the patient like that. Because scanning is there, and if you have ceramide, half an hour you can give your props. Technically, PG scan by you can extract the tooth on the same day you can deliver. In fact, you can advertise. We do props set. So half an hour you can actually finish it off. So now the second aeration will happen when the patient comes back for crown. So you cannot roughen the tooth, so you only aerate. And 50 microns Any other questions? And if you have, keep thinking. After the break, we will still continue, Shishir will continue. And then we'll start with the demo in the model. And you can see the ceramist, how he is doing on crown or a overlay or an inlay. Choice is yours, whichever you want, I can teach you. And then tomorrow, we'll have a lecture on photography. Again, that's more of science. The last module, I'll get my cameras. So you will see mirror cameras, you will see mirrorless cameras, you will see film flashes, you will see ring flashes, and then you will see whatever flashes are available. I'll get everything. So that you will see how it looks. Okay? Yes, I will get it. I will get the macro and I'll get you 400 mm lens. Last month we'll have full more clinic. But I want you guys to think and then I want you guys to interact. Okay, that's when you will also learn, I'll also teach. Okay? Fine? Good then. So we'll have a short break. Come back as fast
As fast as
जो भार है सबसे भार
मेरे पास सबका लैपटॉप नहीं पड़ा, ठीक है?
अभी आएंगे
अभी ब्रेक के बाद से आएंगे। अभी फिर से आएंगे। Comfort give me a laptop here.
You guys are not coming.
बाईस में जाकर कुछ बंद करना पड़ेगा, उसमें लिख रहा 22 में जाकर बंद करना पड़ेगा। चल उसे शाम को फ़ोन करिए 6 बजे के